Okay, the next factor deficiency is factor 8. You notice we're going in decreasing order on these numbers, okay? So factor 8 deficiency, basically that's part of the intrinsic synase complex, which means it binds to factor 9 in order to activate factor 10. Calcium is important to that. I think calcium is important in these complexes. These factors have negative charges. What's going to hold two negative charges together? And just how many positive charges you're going to need? 2. What's calcium doing? 2. Very fortuitous, right? So they're important with that. Now, as far as the factor 8, it's basically it's activated it's changed into acting factor A by minute quantities of thrombin. And so this is basically how it keeps going and everything. Now, as your thrombin concentrations increase, then when it reaches a certain level, it'll shut off this activation. So it's possibly a negative feedback type mechanism in there, an excessive clotting. Okay, now as far as factor 8 deficiency or hemophilia A, it is the most common inherited coagulation factor deficiency in man, dogs, and cats. It's also reported in breeds of horses such as the Arab standardbreds, thoroughbreds, quarter horses, and also in Hereford cattle. And see this picture. Okay, come on. Well, sometimes I hate this. Okay, there we go. So you see it's got a lot more pictures on this particular slide because there's a lot more breeds associated with it. Now, it's not any particular breed as far as dogs and cats, lots of different breeds can get it, but these are the other animals that most often as far as horses and cattle. Now, factor 8 deficiency in humans and animals, it rises as a result of a spontaneous mutation in your factor 8 gene, and that is also on the X chromosome. So this is a sex-linked process also. And so again, males are usually affected while females are usually asymptomatic carriers unless you breed an affected male and a carrier female together. Okay? So basically, the birth of affected female progeny requires that. Now, as far as the clinical signs, they're dependent on how much of the activity is lost. In other words, if it's about 29%, which is still effective, you may not see as many problems. But if it's 1%, you're going to see all kinds of clinical problems with it. Again, you're going to get spontaneous hematoma formation just from playing or bumping into things. Hemarthrosis, bleeding into body cavities. These are very common in moderately and severely affected animals. If you have mild deficiencies, again, they may not be detected until the animal goes through a traumatic episode or some type of surgical procedure. Recurrent shifting leg lameness may be the only manifestation observed in these mildly affected. And that is also due to a little bit of hemarthrosis. It's not severe enough to cause lack of use. It's enough to make some pain, so it will shift back and forth. Okay, this is a German Shepherd that had mild factor 8 deficiency. You can see the hemorrhages on the abdominal cavity there, some ecmotic hemorrhages on there. And this didn't occur until after the animal was castrated. And that's when we found, oh my heavens, this animal had factor 8 deficiency. Okay, after a surgical procedure. It's a good thing it was mild because do you think the animal would have lived? No. Now, most affected individuals, again, will have a prolonged APTT and ACT, but again, specific diagnosis is going to require assay for a specific factor. Carriers usually have, again, between 40 to 60%, and they will not be detected by these coag screens. You have to do specific factor analysis for this. Treatment's the same as what we said before. Fresh plasma, fresh frozen plasma, cryoprecipitate, etc. And again, these conditions cannot be cured. Okay, you just have to treat them symptomatically for as long as the animal lives. Now, factor 7 deficiencies, also known as proconvertant serum prothrombin conversion accelerator, or co-thromboplastin. That's why you can see I like used to learn numerals better. All those different names, but it's again serine protease. It is vitamin K dependent. What part of the coagulation cascade is it in? The extrinsic. Okay, it's the one in there. And it's activated by a tissue factor, which is also called factor 3 sometimes. with calcium present and phospholipids. In other words, your tissue factor will be released when you have damage to the endothelial surface. And so that's going to activate factor 7. And once it becomes activated, it will form a complex with factor 3 and calcium to activate both factors 10, which is in the common pathway, and factor 9. Once 10 is activated, that's going to produce the thrombin. When you get certain levels, that's going to go up and make sure you get even more activation of the intrinsic pathway. We'll also release an inhibitor, which will stop the extrinsic pathway. We don't need it anymore. When the intrinsic is activated, you don't need the extrinsic to be working. Okay? Now, deficiency has been recognized in the colony-bred Mongols or Mongols. Those are those nice crossbred dogs now. Also, beagles, miniature schnauzers, Alaskan Malamute, boxers, and bulldogs. And the inheritance pattern in beagles is autosomal with incomplete dominance, and those colony-bred Mongols is autosomal recessive. There's just showing you some of the breeds that are associated with it. These are your purebreds. Okay. Now, the disorder is not usually accompanied by detectable bleeding, and that's because the intrinsic system can basically, once you have a deficiency, you start a little bit of bleeding, then that's going to activate the intrinsic system after time. And so basically, you're not going to see detectable bleeding. It just may be some little bit of prolonged response as far as the coagulation cascades are concerned. So you may get bruising or prolonged bleeding following surgery, postpartum hemorrhage, and hematoma formation. But if there's nothing like that going on, it may be undetectable as far as the animal is concerned. Usually how you find out you got it is for some reason you did coag screening, and that's how you find it. And it is characterized by prolonged PT, as we said, but the APTT and ACT are going to be normal. Okay. Now, factor 2 deficiency, how threatening to life do you think that would be? If you don't have prothrombin, what are you not going to have? And what if you don't have thrombin, what are you not going to have? Fibrin. If you don't have fibrin, what are you not going to have? A clot. Okay? So it's factor 2. It's a vitamin K dependent again. It's cleaved by the prothrombinase complex, which is the 10 and 5 complex, into the active thrombin molecule. And thrombin is what basically cleaves fibrinogen to form fibrin. So it activates your fibrinogen. And activated or inhibited by numerous compounds such as antithrombin 3. Why do you think they call it antithrombin 3? What does it do with thrombin activity? It inhibits it. And so this is one of our, and what's heparin, how's the heparin act as a anticoagulant? Enhances antithrombin 3. So you enhance that, what do you do it under decline? You're going to inhibit it because you inhibit the thrombin. Okay. So what do you think one of the treatments for DIC might be? Heparin, if it's early. Okay. Now, alpha-2 macrolide is also one of the inhibitors. As far as the deficiencies, they are extremely rare because, if the animal died, what's just going to happen to the animal? You're going to die, okay? It's only been described in man and in the English Cocker Spaniel and Boxer breeds. What else is not in boxers? Actually, all the neoplasms, maybe don't live long enough to show this stuff, right? Man and boxers is an autosomal recessive inheritance pattern. As far as disorder, also in boxers can be a dysprothrombonemia. What does that mean? What's this mean? Abnormal. She may actually have the thrombin there, but it's not normal, so it doesn't work. Okay, so MASH not actually be a deficiency, but if it doesn't work, what's the difference? None. Okay. Now, signs will include epistaxis and gingival bleeding. Bleeding episodes will tend to become milder as the dog matures. It seems to be because the other, for some reason, other things can give you sources of thrombin, which can help supplement it. But if they get too much of a loss of it, they're not going to mature, as far as that is concerned. They will have very easy bruising. You can have dermatitis with it. And what's going to happen to you? What screens are going to be prolonged if you have thrombin deficiency? APTT? 50-50 chance, yes or no?
Yes.
Yes. How about PT? What do people belong? Remember, PT is extrinsic and common. Factor 2 is missing in the common. What happens to all those? Yes, they're all prolonged. The activated body time will be prolonged. And again, the treatment's the same as for your other factors. Just give the factor. Okay? Now, factor 1 deficiency or dysfunction. As far as fibrinogen is concerned, it's a protein that has 3 pairs of polypeptide chains, and those are what are cleaved by your thrombin to form the fibrin clot. So you get just a chain with one monomer of fibrin in there. Okay. Now, as far as this cleavage, it gives you these fibrin monomers that will aggregate in a very irregular array. Is that going to be a very good clot? So what makes that fibrin array get more uniform and become a good clot? What factor? Factor 13. Okay, so that basically thrombin also activates factor 13, so it not only makes the thrombin, the fibrin to form, it also makes the fibrin put together properly to form a good clot. As far as congenital A fibrin, what's A fibrin anemia mean? What's A mean? Not a lack of. It's been reported in one family is Italian dairy goats. Okay. Now, hypofibrogenemia has been reported in St. Bernard and distal breeds, and in these animals, bleeding was very severe. All the coag panel on tests were prolonged. They had low fibrinogen and fibrinogen antigen. So why do you think it's only these few animals that we see it in? If you have afibrinogenemia, are you usually going to live very long? No, because it's very fatal. Now, as far as dysfibrinogenemia with abnormal structure and defective function, that's been recognized in one inbred family of Russian wolfhounds. And again, your coagulation screening tests and everything are going to be more prolonged. You will also get a detection of antigens with fibrinogen, which may be why we've got dysfunctional fibrinogen. And the animals will have mild bleeding episodes, manifest about lameness and epistaxis. But if you have challenging with surgery, it can be life-threatening. And so, in other words, there's enough functional fibrinogen there that the animal will survive, but with any challenges or any abnormal trauma or something, that's when it manifests itself. We give all those dots on those dots on there, they're not supposed to be there. Okay. Now, as far as dysfibrinogen, afibrogen has also been reported in the border Rochester lamb, and had chronic swelling, bleeding from the umbilicus, recurrent periorbital swelling, chronic infection of an ear tag. Because what else is fibrinogen besides a coag protein? Acute phase reactant to inflammation. So that's one reason a lot of inflammatory infectious processes are associated with this. Now, defects in vitamin K metabolism. What kind of vitamin is vitamin K? Fat soluble vitamin. And it acts as a cofactor for the enzyme gamma-glutamyl carboxylase, and that's what activates coagulation factors 2, 7, 9, and 10 within the liver where the prefactors are made to make those factors. Notice there's no A's on these. This is the inactive factors that vitamin K causes to be formed. And these are then released into the blood, and then they will activate depending on demand. It's also required for synthesis of protein C and protein S, which are those inhibitors of coagulation that we see. So vitamin K deficiency and deactivation is one of the most common causes of acquired coagulopathies. What kind of conditions can cause low levels of vitamin K? About low in the diet. Now, what kind of vitamin is it? So what if I have pancreatic insufficiency? You can't get it that way. What if I have a liver insufficiency, not making enough bile acids and stuff to do stuff? Yes. So if you look at this, this is the cycle that is in the liver. It's called the vitamin K epoxide cycle. And basically it shows you how they're making these different activating the prefactors to form the prefactors on these things. And why are rodenticides on there? What kind of rodenticides are we talking about? How's warfarin kill a rat? How's it kill a rat? And then it's vitamin K. So what's that rat die of? Bleeding. It's bleeding disorder. Okay. How's it kill the dog? Same way. How can it kill the kid? The same way. All right. So as far as defects in vitamin K metabolism, there are inherited disorders involving the vitamin K dependent enzymes. This has been reported in the Devon Rex cat and also in the Rambolet sheep. The Devon Rex cats, both male and female, have hematomas, conjunctival hemorrhage, hemarthrosis, massive bleeding in the body cavities. You're going to have all your coag screens prolonged and everything. Now, as far as these are defects in your fibrinogen levels, does vitamin K have anything to do with fibrinogen? No. So your thrombin time will be normal because your fibrinogen is normal. What about your APTT? Why is it prolonged? Vitamin K deficiency. Where's 9? Where's factor 9? Intrinsic. Where's factor 10? Will the PT be prolonged? Factor 7's in there and factor 10. So in other words, you're getting multiple factors. So how come I know that's not DIC? Don't tell me I don't have DIC. You gonna have any clots forming? Are you gonna be using any fibrinogen? So will your thrombin time be normal? Your thrombin time is functional fibrinogen. You're not gonna have FTPs. So that's how we can differentiate because the clinical signs can be very similar and we're bleeding. Okay. Now, as far as pardon me, the factors, the ones that are already in the blood will not be affected by vitamin K deficiency, but you're not going to replace them. Which one has the shortest half-life? 2, 7, 9, and 10, which is the shortest half-life? Take a guess. No, 7. Sorry, wrong guess. So which coagulation screen will be prolonged first? 8. No. It's factor 7, that's going to be the PT. So if an animal comes in and the owner says, I think he just ate some rat poisoning. You're not seeing any bleeding, but you do a coag screen and prolongation of that PT is there. What does that tell you? The animal probably did. Probably got into that. And what's going to happen if you don't give that animal something to get rid of that rodenticide from its GI tract and everything? Then you're going to start getting prolongation of your APTT and very severe clinical bleeding. Okay? What's treatment? Vitamin K. Give vitamin K. Okay, one time. Give it until you get 2 normal coag screens within a 2-week period. Is what you're going to do it. Okay. Now, as far as your metabolism, vitamin K metabolism, that's much rarer than a vitamin K deficiency. Okay. So as far as your Rambolet sheep, you're going to have appearing at a very young age, both males and females. You're going to see all kinds of bleeding problems, and they usually will die from hypervolemic shock from the bleeding and everything. And again, your ACT, your PT, your APTT will be prolonged, and you're going to have decreased activities of factor 9 and 10 in these also, basically. All right. Now, as far as inherited disorders of inhibitors, basically, inhibitors antithrombin 3. So what do you think you're going to have if you have a deficiency of antithrombin 3? You're going to interfere with clotting? Or are you going to interfere with lysis? Or you're going, not so much lysis, you're going to interfere with the restriction of clotting. In other words, antithrombin 3, because while you're making thrombin, what's thrombin going to induce? Clotting, right? Okay, but when antithrombin 3 comes in, it stops it. What if you don't stop the thrombin from forming clots? Well, you're not going to get DIC, you're going to get thrombosis everywhere. Make sense? In other words, the antithrombin 3 limits the clotting mechanism. Okay, if you don't have that, then it's runaway clotting. And so what's going to happen to every vessel, basically? You can get clots in it. So that's one of the problems you get. You get a lot of recurrent thrombosis going on, And if it occurs in little minor vessels, like the major vessels going into the kidneys and everything, what's going to happen? They're going to be healthy or are they going to die? They're going to die, so you get those types of problems. Now, as far as inherited deficiencies of your protein C, which is also a thrombotic protein, it's been reported in thoroughbred colts, and they had recurrent venous thrombosis with it. In human patients, these inherited deficiencies will predispose patients to deep venous or arterial thrombosis. And depending on what vessel that occurs in, depends on how long they will survive. Now, there are some acquired abnormalities, inhibitors seen in animals, and most of them will be an antithrombin deficiency in DIC or protein-losing enteropathies or nephropathies. In other words, antithrombin 3 is about the same size as albumin. So what's going to happen if you have a renal disease problem? You'll keep it in the blood, or is it going to leave? It's going to leave, and that will give you a deficiency in that. Okay. And one of the big things you'll see with antithrombin 3 deficiencies is a lot of renal thrombosis, which makes the problem even worse. Okay, so those are the deficiencies in things, as far as those are concerned. Now, y'all been asked about your test. I still have one more person in your class that has to take the test. They're supposed to take it today. Hopefully, when they finish, it will be posted on. I'll post it on Blackboard tomorrow. Okay. Okay. So again, we know how we classify disorders, right? So let's look at some acquired hemostatic disorders now. We talked about the congenital. Let's more look at the acquired one now. What can cause platelet problems? Can some drugs do it?
Yes.
Can some infectious agents do it? Can some vaccinations do it? Now, as far as acquired disorders, these are the most common abnormalities in hemostasis that we will see. And in particular, immune-mediated thrombocytopenias, anticoagulant organocyte toxicosis, metabolic diseases that affect hemostasis, and DIC. Right, these are the main ones we will see. These are acquired disorders. And they can occur in an animal at any age, and animals that will present with clinical signs of hemorrhage, you basically need to examine for an underlying disease that may be causing it, because these are much more common than inherited things. So we'll rule out those before you think this animal may have a inherited disorder going on. Now, again, drugs can cause or exacerbate a bleeding tendency. So what do you need to know from the owner? What drugs these animals on? Well, the owner said, I gave some aspirin yesterday. Does that cause platelet function problems? Okay, so we need to get a good thorough history with these things. Acquired defects of the vessel wall. Vasculitis can be caused by a lot of different infectious agents, also by immune-mediated causes. And if you have vasculitis, is that going to cause bleeding? Is that going to cause platelets to come in? Can that use up your platelets? Basically, so that can basically give you a thrombocytopenia like that, can it? And these infectious causes include this and many other things, but herpes virus infection, Rocky Mountain spotted fever. Who first reported Rocky Mountain spotted fever in a dog? Huh? And Dr. Hill, Tuskegee graduate, and I think it's North Carolina, where he practiced well. And immune-mediated vasculitis and purpura hemorrhagica. What's purpura hemorrhagica supposed to do? Streptococcus infection, unfortunately. Okay, as far as herpes virus infection, it's going to be sporadic. In other words, not all the time you're going to see it. But it can result in rapid death of puppies, usually between about the ages of 7 and 21 days. And it's characterized by multiple hemorrhages throughout numerous tissues, including liver, kidney, brain, GI tract, and lung. And basically, it's a viral-induced necrotizing vasculitis. So puppies will usually die within 24 hours of getting this particular infection. And treatment is usually unsuccessful. Now, as far as Rocky Mountain spotted fever, what's the cause agent? Rickettsia or CCI. And basically, they haven't changed the name on that yet. They probably will before y'all graduate, but they haven't changed it yet, okay? It is an obligate intracellular parasite, transmitted mainly by Dermacentor variabilis and Dermacentor andersoni ticks. It invades the vascular endothelial cells, causing necrosis of those cells. If you have necrosis of the endothelial cell, what happens to the permeability of the vessel? It increases it. And so what are the platelets going to try to do? It'll stop the bleeding, but if it's all over the place, what's going to happen to your number of platelets? It's going to decrease like crazy. Also, sometimes it has shown that the platelets themselves may be affected by some immune complexes that produce as far as this disease is concerned. As far as Rocky Mountain spotted fever, it gives you basically hemorrhages all over the place. One of the main things you can see is retinal hemorrhages. That's sometimes one of the first things that you use to diagnose the condition with. And if you keep going on, you can get DIC. It's this. Now, tetracycline and chlorphenicol is recommended therapy. Depending on how soon you get it, it may not be effective. Immune vasculitis, as far as various causes for that, what it is it's deposition of immune complexes in your small vessels. They damage the wall, so you get leakage of plasma, blood cells, and stuff. And this is going to activate both the coagulation cascades and use up platelets and stuff. And the antigens involved in the complexes can be autoantigens or antigens of infectious agents. So there's, it's all. So what do you think is more common, Rocky Mountain spotted fever or this kind? This kind is the most common problem. And basically, you're going to see the signs of platelet problems. Tissue necrotic hemorrhages everywhere. And the most well-known syndrome, again, is the purpura hemorrhagica of porpoises and necrotizing vasculitis in beagles and Bernese mountain dogs. This is a Bernese mountain dog right there. Okay. So purpura hemorrhagica of horses. Basically, it's a very acute onset of this disease. You get edema of the head, limbs, vitiation of mucous membranes. And one of the problems is that it has damaged epithelial, endothelial surfaces and stuff. And when you damage that, it causes the bleeding and all this type of thing. And this section right here is a skin lesion from purpura hemorrhagica in a quarter horse. And what's in that blood vessel right there? That's a clot. That's an infarction. So what's happening to the tissue that has been there above it? Necrotizing stuff and everything like that. And basically, it is a syndrome that can follow Streptococcus equine infection. And what's the common term for Streptococcus equine infection in horse? Strangles. It's one of the things you can see with this. There are acquired disorders of platelet numbers. What do you think is the most common acquired disorder? About trauma. Trauma going damage and use platelets and stuff. That's the most common. So again, as we say, if I ask you to rank bleeding disorders according to the most prevalent to least prevalent, what would be the first thing? Platelet numbers due to trauma and stuff. Okay. Now, acquired thrombocytopenia are usually trauma-induced. They can also be immune-mediated. It is, again, the most common hemostatic disorder counted in practice anywhere else. So anytime an animal comes in with a bleeding disorder, besides the bleeding time, what's the first test you look at? About platelet numbers. Look at your platelet numbers. And rule that out, okay? And it can occur, acquired thrombocytosis can occur with primary myeloproliferative disorders, or there can be some, just for some reason they got an increase in the lifespan. They don't really know why, so they hang around longer. Now, as far as acquired thrombocytopenia, basically they can be either due to decreased production of platelets, increased consumption of platelets, increased destruction of platelets, or sequestration of platelets. Sometimes, for some reason, the spleen says, hey, come on, platelets, come here and stay with me for a while. So they can be accumulated in there. But what's the most common cause of low platelet numbers on hematology results? They're clumping. So it's really not there. This is just showing you they're clumping. You have to rule that out before you say, oh yeah, we do have a thrombocytopenia going on. Okay? As far as decreased platelet production, usually it's not just going to affect the platelets, so we usually see decreased production of other bone marrow cells. So usually you're going to have more of either a bicytopenia or pancytopenia if this is the problem. And so usually you're gonna see those problems. Now, acquired causes of decreased bone marrow production of platelets can be bone marrow aplasia or hypoplasia. What's the target of some drugs as far as toxicity is concerned? The bone marrow. Those are things like your sulfonamides, your rhizophobin, estrogens can also do it. Brachyfern poisoning in cattle, ehrlichia canis infection. Remember, it causes severe problems as far as bone marrow. And idiopathic meaning what? What's idiopathic mean? We don't know why, but they're most likely immune mediated, but we can't prove that. Okay. Now, leukemia. What's a leukemia mean now? What's a leukemia? Hematopoietic neoplasm bone marrow origin. And does it care what it's wiping out when it's reproducing in the bone marrow? So if it wipes out to megakaryocytes, what's going to happen to your platelet numbers? They will decrease. Okay. But generally, these animals will have a pancytopenia if this is what you're having problems with. What's myelocytosis mean? Replacing the normal marrow animals with abnormal, it can be neoplasia, but it can also be fibrosis and stuff. In other words, and also ineffective hematopoiesis. In other words, not doing what it's supposed to do. And things which can cause this are your myelodysplastic syndrome in cats that we saw, and also ehrlichia infections such as ehrlichia canis, immune-mediated. So in other words, very often decreased platelet production is not going to occur as a single entity. It's going along with problems just called decreased production of anything down the bone marrow. Now, increased platelet consumption, basically anything which causes hemorrhage and excessive coagulation. What are you going to see with DIC as far as platelet numbers are concerned? What's making the clots? So using up the platelets, can the bone marrow keep up with it? No, so you're going to see low platelets with that. Severe acute hemorrhage. In other words, acute hemorrhage can pull the platelets out before the bone marrow can respond. Now, hopefully, if you control the hemorrhage, then the bone marrow can respond and then put out your platelets like you need to. But usually, your platelet counts usually are not less than 50,000. If you could do a platelet count, that'd be clumping and stuff. Okay. And also, thrombocytopenia can occur due to increased platelet destruction. This is generally a result of immune-mediated processes. Immune-mediated thrombocytopenia, autoimmune-mediated hemolytic anemia in dogs can also involve platelets, stuff as far as that's concerned, or any infectious agent that causes immune-mediated anemias can cause affect the platelets also. But it's basically no routinely available procedure to determine if we have an immune-mediated thrombocytopenia due to a specific antibody against those platelets. But you have to basically send them off, and they've got research labs that are doing those. You're going to send the animal. Anytime you're dealing with platelets evaluation, you're usually going to send the animal. Because how long do platelets survive after you take them out of the body? Not very long. Okay? So immune-mediated thrombocytopenia, or ITP, is diagnosed most often in dogs. You sometimes see it in cats and horses. And if you see there's a normal blood smear down the bottom, what about that one on your all's right there? What are you not seeing there? Platelets. Now, what am I going to do before I say that this is immune-mediated thrombocytopenia? I'm going to go over to the feathered edge and see if I see clumps of platelets and stuff, because you've got to rule that out, right? And one of the reasons it's not diagnosed very often is because we may not be able to differentiate it from just normal uses and function. Okay? So primary immune-mediated thrombocytopenia, or ITP, primary ITP is a clinical syndrome of very acute onset. You get small vessel bleeding, in other words, the capillary bleeding and stuff. Usually you're not going to see any other problems as far as systemic illnesses in the dogs that have these. The degree of anemia will depend upon how extensive the hemorrhaging is and how much blood loss you've got. As far as the diagnosis of primary ITP, it's finding thrombocytopenia with normal coagulation test results and splitting anything else which can cause the problem. So how easy is it to diagnose it? It's not that easy because there's so many other things which can cause decreased platelet numbers. But what you're going to do is you're going to treat it. What are you going to treat immune-mediated thrombocytopenia with? What are you treat any immune-mediated process with? Steroid. You give the animal steroids and the condition improves. So that tells you, yes, this was probably immune-mediated thrombocytopenia. Okay? Now, basically, this corticosteroids you usually will, you know, corticosteroids usually will give you a very quick response, this type of things. But sometimes this quick response won't last very long, so then you're going to have to use more prolonged treatment. And sometimes these drugs are almost as bad as the condition itself. Use a combination. Okay. Now, primary ITP can also be part of a more generalized immune-mediated disease, and basically such as, well, y'all know about systemic lupus erythematosus? Y'all know about that? What's the disease? What is it targeting? Lupus erythematosus. Not just when there's the skin. It can attack anything which has a nucleus in it or nucleic acids in it. So can it target like megakaryocytes and stuff? You destroy megakaryocytes, what do? Platelet numbers? Decrease them. So basically, systemic lupus erythematosus is basically an immune disease directed against nucleic acids, this type of thing, okay? And if you've got it where you have decreased numbers of megakaryocytes in the bone marrow, then you have to worry about systemic lupus erythematosus being a problem. Now, unfortunately, it's not that common, but it's getting increased incidence in recent years. As far as secondary immune-mediated thrombocytopenia, that can be caused by all kinds of different things, particularly your Ehrlichia canis and your Ehrlichia organisms can do it. Panleukopenia, parvovirus, and cats can do it. Boviviral diarrhea virus can do it. So basically, babesiosis, any of this type of thing can cause secondary immune-mediated thrombocytopenia. Okay? And very often we may not be able to figure out what it is very often. A lot of drugs can do it. So sulfonamides, polythiuracils, penicillin, anything that antimony, gold compounds and stuff that we use for treatment of various things can do it. It can also be secondary to various neoplastic diseases such as lymphoma and a variety of your different tumors. Both benign and malignant can do it. Again, a neonatal thrombocytopenic purpura been recognized in pigs, mules, and herbivores. And basically, this has been an antibody that's against the sire, and basically it coats the platelets and gets out the platelets and stuff. So in other words, there are all kinds of things that can cause thrombocytopenia. And that's why you have to get a very thorough history of what this animal may have been exposed to or is currently being exposed to before you try to make a diagnosis. And sequestration again, the spleen can sequester. This is a big spleen right there, isn't it? And anytime you get an enlarged spleen, due to many reasons, it can cause collection of platelets inside that spleen and give you thrombocytopenia. Bacteremias are one of the things that can cause platelet sequestration in organs and stuff like this. So animals that have these diseases are also likely to have BIC. And basically, what's that going to do to the thrombocytopenia? That's going to help it out or make it worse? It makes it worse. Okay. As far as acquired thrombocytosis, and what do you mean? What's acquired thrombocytosis mean? It means you're producing more platelets, right? And acquired means it's not due to an inherited disorder, right? And basically, it's been seen in various. Certain neoplasms can cause it, some inflammatory diseases can cause increase in your platelets, tissue damage and everything. Because, that's going to list the factors which are going to induce the bone marrow to produce more platelets. But to increase platelets usually mean a whole lot of problems. No, and if we have a neoplasm involving your megakaryocytes, you'll see increased platelets, which will be bizarre looking platelets. usually you can diagnose that much better. And basically, in cats and dogs, you can see very high from lymphocyte numbers, plasma cell numbers with lymphomas, GI tract disorders such as pancreatitis, chronic hepatitis, inflammatory bowel disease, and are some of the most common disorders in cats and dogs. Those right there. And also in diabetes mellitus, hypercorticism, hypothyroidism, all these can give you an acquired thrombocytosis. Colic can in horses. Now, what it means is that this damage is causing the release of those different types of cytokines and various factors which are going to stimulate the bone marrow to produce and release more platelets. Now, what can that cause a problem with as far as serum chemistry evaluation? Anybody know? Huh? Can't hear you. No? The problem is you can call platelets very high in potassium. And are platelets very stable, or when you take the sample, you're going to lyse a lot of them? So if you had a bunch of them, what's your potassium level going to be in your sample? Very high. Oh my heavens, I got to give this animal something to lower potassium level, right? It's not due to that, it's artifact. So that's why you need to look at your platelet count. If it's very high, then that more likely explains why you got that high potassium levels in there. As far as neoplastic thrombosis, basically, myeloproliferative disorders can sometimes involve the megakaryocytes, and that can give you platelet counts of greater than 1 million per microliter. And this is in a sample that you pull it and set for a little while, it's still this time. Okay? And basically, essential thrombocythemia, in other words, essential means it's primary thrombocytopenia, has been documented in dogs and cats, and it can also occur with other myeloproliferative disorders such as polycythemia vera. This type of thing can give you increased platelets. Now, as far as disordered function, again, acquired are very common, drugs, various diseases and things. We all can read through these because just about everything can do these types of problems. Okay? And so basically we're going to call it quits for today. And you notice we've lost a lot of classes in this course. That's, how many Fridays have we lost? How many Fridays are we going to lose this week? So basically, for some reason we're really behind in this stuff. And so to catch up, I may ask you all to give me a few extra hours periodically, and I will reward you all by giving you bonus questions on exams and stuff. Okay, but I want y'all to get the material. And unfortunately, we lost a whole week, when it snowed. And we never lost contact, of course, with the snow before. Okay, so do that. But again, now as far as the problem base, I'm going to grade your papers over the Easter holidays, and I will basically, what you need to do is to get with the other people that had your same case, because you all will be get together to do a PowerPoint presentation of that case. Don't have to be as detailed as the ones we've done with our various cases, but to basically do it so it basically explains what's going on, this type of thing. And next Friday, we will start those presentations. And then we will have, there's 3 Fridays left in that course. 1 Friday's taken up with lymphatic. There's 3 Fridays left. And we had 20 cases, so we're going to have to do at least, 8 of those cases, 7 to 8 of those cases every Friday, all right? We're going to start at case number 1 and go through. So I'll have this graded so you will be able to get your exams back, your papers back on Tuesday. On Tuesday, and then just get together with, there's 2 to 3 people per group. Okay, and so get together and work on those, okay? All right.